A patient is diagnosed with nephrogenic diabetes insipidus. Which class of drug is least likely to be effective in this condition? So, what is basically nephrogenic diabetes mellitus? Here, even when the ADH is synthesized or ADH is present in the body, the kidney is not responding to this ADH. So, in that case, desmopressin, which acts like a ADH analog, will not be of use when we give it in nephrogenic diabetes mellitus. NSAIDs and thiazide diuretics help by reducing your urine volume and amount. And amiloride is mainly useful for lithium-induced diabetes insipidus by blocking the epithelial sodium channels. So the answer here is desmopressin. Now coming to the next question, a 55-year-old male with history of hypertension is prescribed hydrochlorothiazide. After few months, he presents with severe pain and swelling in the first metatarsophalangeal joint. So what is he having? Gout, right? And his serum uric acid levels are elevated. Now, which of the following best describes the mechanism by which hydrochlorothiazide contributed to this patient's condition? Inhibition of xanthine oxidase leading to uric acid accumulation, increased renal reabsorption of uric acid reducing its excretion, decreased conversion of uric acid to allantoin reducing excretion, inhibition of urate transporters in the proximal tubule leading to hyperuricemia. It is actually increased renal reabsorption of uric acid reducing its excretion. So one of the drugs that cause there is primary gout and secondary gout. So drugs are important cause for secondary gout as well as cancer conditions. Wherever there is increased cell turnover, that can lead to increased production of uric acid. So drugs, among drugs, hydrochlorothiazide as well as loop diuretics like furosemide, pyrazinamide and all can cause, can precipitate gout by decreasing the increasing the renal reabsorption of uric acid and reducing its excretion. Now, a patient with congestive heart failure is prescribed furosemide. Which of the electrolyte disturbances is most likely to occur with prolonged use of this medication? First of all, with congestive heart failure, only in case of acute left ventricular edema, pulmonary edema, we prefer giving furosemide because of its rapid venodilatory and redistribution of blood from the pulmonary to systemic circulation. Otherwise, we prefer giving agents like spironolactone by preventing the ventricular remodeling. Now, what is furosemide? Furosemide is a loop diuretic and it acts on the loop of Henle. That is why it is called loop diuretic. And what are the electrolyte imbalance it can cause? It can cause hyponatremia, hypokalemia, hypocalcemia and hypomagnesemia. So among the options, the answer is hyponatremia. Which diuretic causes hypercalcemia? It is the thiazide diuretic. So in the afternoon session, we'll see the image-based question. We'll see the site of action of each of these diuretics, which is commonly asked. So thiazide, you can remember it as loop loses calcium, whereas thiazide retains calcium. So thiazide causes hypercalcemia, whereas loop diuretic causes hypocalcemia. Coming to the next question, a woman using combined oral contraceptive pill presents with headaches and elevated blood pressure. Which of the following components of the combined pill is most likely contributing to this effects? So, patient has headache and hypertension. So, both this hypertension as well as the headache component or migraine component is because of its estrogen component, and the estrogen in combined pill is ethinyl estradiol. So combined pills have got many side effects. We have minor side effects which appear later, and serious side effects, right? So minor side effects, like we can have this nausea, vomiting, mastalgia and all. Side effects which appear later includes weight gain, hair growth, acne and all, mood swings and all. Now we are more concerned about the serious side effects. What are the serious side effects that you see with OCPs? It can cause cardiovascular side effects. What cardiovascular side effects? It can lead to thrombus formation. Thrombus formation in the sense, it can result in myocardial infarction, it can result in cerebrovascular accident or stroke, and it can cause thromboembolism also. Deep vein thrombosis is also seen. Cerebrovascular disease, and it can cause hypertension. So the thrombus formation is because of increased coagulopathy by factor 8, 9, 10 and 11 is increased with the estrogen component. Hypertension is because of the increased production of renin and angiotensin 2, and all this are because of the estrogen component. Then it can lead to certain cancers. Okay, there is increased risk of breast as well as cervical cancer. It is protective against ovarian and endometrial cancer. It is mainly because of the progesterone component that has this protective effect. Ovarian, I remember it, main mechanism by which OCP acts is by inhibiting ovulation. So each time ovulation happens, there is a scar on the ovary which can precipitate the uh, uh, risk of cancer. That is how I remember it. So it is protective against ovarian and endometrial cancer, but it can increase breast and cervical as well as hepatic adenoma is also seen. Then it can also cause gallstones. Smoking, obesity and all are relative contraindications for use of OCPs. Absolute contraindication, even diabetes. So absolute contraindications includes a thromboembolic event or MI or recent cerebrovascular incident or breast cervical cancer or undiagnosed vaginal bleeding, all are contraindications for OCPs. Now, which of the following corticosteroids is preferred for treatment of adrenal insufficiency due to combined glucocorticoid and mineralocorticoid effects? Dexamethasone, hydrocortisone, prednisolone or fludrocortisone. The thing that you have to remember here is it is for treatment of adrenal insufficiency. We need agents that have got both glucocorticoid and mineralocorticoid activity. So we have two properties. One is the sodium retaining property, which is reflecting their mineralocorticoid activity. Other one is the anti-inflammatory action. So we have for each drug, we have the anti-inflammatory is to sodium retaining property. So some of them have got, for example, dexamethasone has got only anti-inflammatory property, no sodium retaining property. So they are mainly having only glucocorticoid activity, no mineralocorticoid activity. Some have only sodium retaining property, no anti-inflammatory. So they have only mineralocorticoid activity. So among the options, the one which has got both glucocorticoid and mineralocorticoid activity is hydrocortisone. So if you see this table, you can see hydrocortisone has got anti-inflammatory is to water retention ratio is 1:1, equal glucocorticoid and mineralocorticoid activity. You can see for agents like betamethasone, dexamethasone, only anti-inflammatory, no water retention property is there, because of which we can give it for cerebral edema because there is no water retention property. Now you can see methylprednisolone, triamcinolone and all has got again only anti-inflammatory, no mineralocorticoid activity. Now, a patient with hypothyroidism is started on levothyroxine. What is the most appropriate monitoring parameter to assess the therapeutic efficacy? As we all know, for starting or for diagnosing hypothyroidism, we look out for TSH as well as free T3, T4 levels. But for monitoring the therapeutic efficacy, what do you look out for? We look out for the TSH levels. It should be between 0.5 to 5. We try to maintain it between the midway. A 30-year-old woman in her first trimester is diagnosed with Graves' disease. She is started on propylthiouracil to manage her hyperthyroidism. Which of the following is a recognized congenital malformation associated with the use of methimazole, which is another antithyroid drug during first trimester of pregnancy? So pregnancy, both propylthiouracil and methimazole has got its risk, but during first trimester, we prefer propylthiouracil. You can remember propylthiouracil P for pregnancy. Why it is preferred in pregnancy? Because it is because it is highly protein bound and does not cross the placenta. Okay. So first trimester you prefer giving propylthiouracil, but after that we again uh, change back to methimazole because propylthiouracil can cause hepatotoxicity. Now, when you're giving methimazole, what is the risk when you're giving methimazole during the first trimester? The patient can have aplasia cutis congenita, where there is deficiency of the skin, especially on the scalp. That condition is what is known as aplasia cutis congenita. Okay. Now, a 45-year-old male with long-standing type 2 diabetes is started on insulin therapy due to poor glycemic control with oral anti-diabetic agents. Which of the following types of insulin is most appropriate for controlling postprandial hyperglycemia? So, a long-standing started on insulin therapy, and the question asked is for controlling postprandial hyperglycemia. So we need a very rapid acting agent that we give after each meal to control the postprandial hyperglycemia. Which among this is a rapid acting agent? It is insulin Lispro. So you have rapid acting agents as well as long acting agents. The insulin glargine and detrimer deglutec are all long acting agents. Glargine is called as a peakless insulin. We give this glargine to provide the base level insulin levels, and then you give this Lispro, aspart or glulicin, which are rapid acting insulin analogs, to control the postprandial hyperglycemia. The intermediate acting agents like NPH insulin, though they are intermediate acting, but it cannot very accurately control the postprandial hyperglycemia. Okay, coming to the next question. A 68-year-old postmenopausal woman with osteoporosis is on long-term oral alendronate therapy. During follow-up visit, she reports persistent difficulty in swallowing and occasional chest pain. Upper gastrointestinal endoscopy reveals esophagitis but no malignancy. Considering the known risk associated with bisphosphonate use, which of the following actions should be taken to monitor and prevent potential serious complication of this patient? So bisphosphonates, how does bisphosphonates act? It is a drug of choice for postmenopausal osteoporosis, right? So bisphosphonates is a drug of choice. Now, which are the bisphosphonates? You have the alendronate, zonedronate, pamidronate, and all. What is the most common or which is the most common side effect that we dread with bisphosphonates? It's the esophagitis because of direct irritant effect as well as the reflex effect. So whenever you're giving the patient oral bisphosphonates, What advice will you give them? We ask them to take it an empty stomach, only with one full glass of water, should not take anything else with that to avoid the contact with the esophageal mucosa. Plus, the patient should not lie down for at least half an hour to prevent the reflux. So, these all steps are being taken to prevent this esophagitis, right? And if the patient has this problem, okay, if we don't control it, what can happen? There is increased risk of esophageal carcinoma. So if the patient complains of this, it is always better we switch to IV zoledronic acid to reduce the risk of esophageal carcinoma. Okay, we may start on proton pump inhibitor to manage esophagitis, but we cannot continue with alendronate. We'll have to switch to IV zoledronic acid so to avoid this contact. Though we can start on denosumab, which is another agent, monoclonal antibody, which is against the rank ligand, but bisphosphonates is more efficacious. So we prefer maintaining the patient on bisphosphonates. Though we do surveillance by endoscopy, but regular surveillance is not advised. Okay, so bisphosphonates, IV zoledronic acid to reduce the risk of esophageal carcinoma, which is another. So, how does bisphosphonates act? They uh, inhibit the bone resorption by inhibiting the osteoclast activity, by increasing the apoptosis of osteoclast as well as the prenylated margin and of the osteoclast is being removed when it is a bisphosphonate treated osteoclast. Another agent that we give for osteoporosis is the recombinant parathormone 1 to 34. What is that drug known as teriparatide? We give teriparatide in intermittent pulsatile manner that will stimulate the bone formation, and we should not give it for prolonged for more than 2 years because there is risk of osteosarcoma. With bisphosphonates, another side effect that is characteristic seen with bisphosphonates is osteonecrosis of the jawbone, because of which we prefer doing regular dental checkups when the patient is on bisphosphonates. But still, bisphosphonates is the drug of choice for postmenopausal osteoporosis. And then comes your recombinant parathormone. Then you have denosumab, which is a monoclonal antibody. Then you have SERMs like raloxifene, which is again useful for postmenopausal osteoporosis. A patient diagnosed with acromegaly and started on octreotide. So what is octreotide? It is a somatostatin analog. Which of the following describes the mechanism of action of octreotide? It inhibits the growth hormone release from the anterior pituitary, antagonism of growth hormone receptors in peripheral tissues, inhibition of insulin-like growth factor 1 production in the liver, stimulation of dopamine receptors in hypothalamus. So here in acromegaly, it acts by inhibiting the growth hormone release from the anterior pituitary.